In this next section, we're exploring sexuality and gender-related disorders, which is always a very interesting section to explore. So, obviously, sexual disorders are extremely value-laden, are extremely personal. So think that for clients, there's a lot of shame and judgment associated with these diagnoses. And so they really feel like you're defective in ways that are very simple biological, that most people should be able to do these things and they can't. So you have to be very delicate in the way that you discuss them with your clients. It's incredibly important in this area to rule out things like substance abuse and underlying medical conditions and side effects of medications that can be leading to these types of physiological responses, and also looking a lot for trauma. So a lot of trauma manifests in somatic body-related issues, and a lot of these come out particularly in the area of sexuality and sexual expression. And so for most of these disorders, we do have specifiers related to something being lifelong or acquired based on a certain period of time of onset. And it's important to think about when these things started. Onset matters, because if they start after a trauma situation, if they start after a certain contextual situation, that can be a very important information for you in terms of your diagnosis and your approach to treatment. So it's important to find out not just that these things are going on, but how often they're going on. So in the sexual dysfunction area, we have erectile disorder, we have female orgasmic disorder, we have female sexual interest and arousal disorder, genitopelvic pain or penetration disorder, male hypoactive sexual desire disorder, among some others. So talking about penetration disorder, and in previous DSMs, this was known as vaginismus. So in the link that is provided as part of the module, you'll see an example where they talk about this as vaginismus, and it was known that way for a very long time. Furthermore, the pelvic pain-related disorder used to be known as vulvodynia. Again, this is just persistent pain. So now these are put together into this genitopelvic pain or penetration-related disorder, which is a mouthful, and this disorder involves essentially a lot of discomfort. So in terms of pelvic pain, this involves physical pain with anything related to vaginal intercourse. So this is for individuals who have vaginas. And this pain, again, we want to rule out things like pelvic floor issues or physiological issues. This is fully somatic and psychological. So there's consistent pain during penetrative intercourse, or with penetration disorder, you're finding spasming or essentially the body rejecting the idea of any kind of penetration going on. So you're wanting to engage in intercourse and not able to because your body is essentially rejecting that attempt. Also, you might see marked fear, anxiety, and anticipation of sexual experiences because you're afraid of that this is going to happen. So a lot of it is either physical pain in the skin or physical pain in the tissue, or tensing and tightening of the pelvic floor muscles that essentially reject any attempt at penetration. This has to have been going on for 6 months. And as you can imagine, if you're someone who's trying to engage sexually with a partner and you're having 6 months worth of difficulties in being able to do that on a very basic level, this is 1, very embarrassing, and 2, really difficult for our clients, because that's a long time to be struggling with this without necessarily having an explanation for it. So here we're talking about sexual related disorders for individuals with vaginas versus individuals with penises. So sexual disorders here relate to what used to be called sexual dysfunction. So we're looking at erectile disorder, which means that individuals with a penis are not able to maintain or to get an erection when they want to. and a decrease in the rigidity of an erection when you are able to get it. Again, we're looking at these things lasting for at least 6 months. And then in terms of female orgasmic disorder, you're going to notice these are very strongly on a binary. And I am intentionally trying to not talk about them on a binary. So individuals who have vaginas find that they are not able to reach orgasm or have a reduced intensity of orgasms going on for at least 6 months. Again, super important to rule out things like physiological cause, side effects of medication, overuse of things like alcohol or drug use that could be impacting these sensory issues for them. A lot of times this is related to things like self-worth or trauma potentially. And so we want to investigate when this is a mental health related issue, what some of the underlying causes might be and how we can address those things. So this next disorder is quite interesting. And you might think about, as we're talking about this disorder, how it's very related to cultural context and particularly gender roles. So in terms of female sexual interest and arousal disorder, the symptomology is a marked lack of or significantly reduced interest in sexual activities. And so this might have to do with loss of thoughts or fantasies. This might have to do with loss of interest in actually engaging in sexual activity, not initiating sexual activities, being unreceptive to a partner's attempt to initiate activities, and reduced pleasure, approximately by 75 to 100%. When they are engaging in these activities. Now, it's interesting to note that when this was developed, we didn't really have the concept of asexuality and aromanticism as sexuality expression. And so there's really a bit of a question here related to what is enough or marked interest from individuals identifying as female related to sexual interest. And so, again, we see this is persistent for 6 months. And like a lot of other disorders, a key indicator here is marked distress for the individual. So is this a problem for the individual? So just because you have someone who doesn't have a lot of interest in engaging in sexual activities with others, it doesn't mean that this diagnosis necessarily fits for them. It's really a question of, is this interfering with their ability to function? Is this causing marked distress? And if the answer is yes, then this diagnosis might fit for your client. And again, we're going to be looking at potential underlying causes, history of trauma, sexual history, things like sexual expression, because it might end up being related to a process of learning about sexuality and maybe learning about the types of partners that are more or less comfortable for this individual. So there's a lot to dig into here, and think carefully about context when you're using this particular diagnosis. Similarly, talking about male hypoactive sexual desire disorder, same concept that we talked about with female disorder, they just separated out based on a gender binary for some reason. And so again, same criteria, judgment of deficiencies made by the clinician. So again, you want to make sure to take into account things like cultural context, sexual expression, identities held, age, the time this has been going on, and particularly if this is causing marked distress for the individual. So let's talk about gender dysphoria. So prior to this DSM, this was formerly known as gender identity disorder. There was a movement towards taking the disorder out of the title of this particular diagnosis and calling it gender dysphoria, meaning that there's an incongruence or a mismatch between gender expression and sex assigned at birth. And we've talked about this in other courses too. So we're talking about this here particularly from a diagnostic standpoint. So there was a change of taking disorder out of the title of this to try to minimize stigma and offer more support and acceptance for this community. Now, just because individuals identify as transgender doesn't mean that they meet the criteria for gender dysphoria. And we'll talk about why here in just a moment. So We're going to note there are different criteria for children and for adults. This again is a change. We didn't used to have a lot of options in terms of diagnostics for children. And in terms of treatment interventions, it's important to note that in terms of treatment interventions, mental health-wise, there's a lot of identity development and exploration work that can be done just in helping individuals be able to find and ground their sense of self as they go through the developmental process related to gender identity and expression. And in terms of medical intervention, there are opportunities for medical intervention in the way of things like hormone blockers, which delay the puberty process, which can be particularly helpful when you feel like certain body parts don't fit for you and you don't want them to develop in certain ways. Hormone blockers can delay that process. And then there's hormone replacement therapy, where you're taking testosterone or estrogen supplements to change that developmental process in a different gender expressive direction. It is important to note that nowhere in the United States is anyone performing gender surgery on children. It is not accepted practice. It is not something that's done. So that is not ever something that's on the table for someone under the age of 18. So in terms of gender dysphoria for children, this is marked incongruence between experienced and expressed gender. So sex assigned at birth and gender identity do not match. And this has to have been noted and experienced for at least 6 months. And these are the criterion that we use to determine if that's happening. And you'll see in here, there's some really interesting cultural contexts that can be taken into consideration with the diagnostic criteria for children. They're very heavily based on gender roles and Western views of the world. So looking at things like a strong desire to be of the other gender or insistence that one is the other gender, okay, this makes sense. For boys, strong preference for cross-dressing or simulating female attire, and girls, the opposite, wearing more masculine clothing. Clearly very gender role connected. So just because a male or female child wants to wear different types of clothing does not mean that they are necessarily transgender. Could just be the way that they express themselves. Strong preference for cross-gender roles in make-believe play or fantasy play. Again, who's to decide that this is problematic? Strong preference for toys, games, or activities engaged by the other gender. Strong preference for playmates of the other gender. And looking at things, toys and games that are avoidant of either masculine or feminine types of gender roles. So a lot of these criteria for children are very gender role specific and very Western specific. So this can be somewhat challenging in diagnosing children accurately because a lot of these criteria can apply to a lot of kids, and it doesn't necessarily mean they have gender dysphoria going on. Now, things like a strong dislike of your own anatomy or a strong desire for expressed primary, secondary sex characteristics, probably something that we need to pay close attention to. But noting that you have to have at least 6 of these criteria to meet the diagnosis as a child with distress or impairment because of this. So that doesn't mean that they experience distress or impairment because individuals around them are not okay with what they're doing. It's really a sense of distress in that my body parts don't fit me. That's distressing. That's a really difficult way to navigate the world. And so it's one of those things where if it's not really a problem for the child or their family, really it's important to think about whether or not this diagnosis makes sense. And this diagnosis is often required for individuals who are seeking out gender-affirming care. So this diagnosis is really interesting because you have to consider a lot of contexts when you're assigning it. There is a specifier with a disorder of sex development, which notes some sort of genetic, hormonal, or physical issue specifically related to sexual development. These might be our individuals who are born intersex, meaning that their physical and biological markers of gender are a little more ambiguous. Now, in adolescents and adults, we see the criteria are somewhat different. So here, again, we have the incongruence between sex assigned at birth and experienced gender for at least 6 months. You only need 2 criteria here as opposed to 6 when it comes to children. So here it's incongruence between those gender experiences and sex characteristics. Strong desire to be rid of your own characteristics because of this incongruence. Strong desire for primary, secondary characteristics of the other gender, desire to be the other gender, to be treated as the other gender, and conviction about these feelings. Now, looking at this set of criteria, they make a lot of sense. They, taking a step back, represent the experiences of an individual for whom their body does not fit the picture. These are individuals who are clearly experiencing impairment and distress because of this incongruence. The criteria for children may be a little questionable. Again, here we have the specifier of disorder of sexual development, and we have what's called a post-transition specifier, meaning that they have transitioned to living full-time as their desired gender, undergone some sort of HRT or surgery, and this has been going on for a while. So individuals pre-transition and post-transition are clinical terms that we use to describe individuals maybe seeking out gender-affirming care versus those who are more of a maintenance plan. So the next set of disorders are what are called paraphilic disorders. These are pretty interesting. They have a lot to do with sexual expression. And again, important to examine the cultural context in which we are describing these disorders. So the first being voyeuristic disorder. So for a period of at least 6 months, this is the individual who gets arousal from observing unsuspecting persons who are naked in the process of disrobing, engaging in sexual activity, etc. These are our peeping toms. These are individuals who hide and like to watch other people without their consent, which is the part that is problematic here. There's nothing wrong with individuals finding sexual gratification through watching other people engaging in activities. The key piece there is having that consent. And so this individual's acted on these urges, so it's not just thinking about it, it's not just something that's arousing to them, but they have acted on these urges with a non-consenting person, and that is a crime, literally. So this obviously causes significant distress and impairment in their ability to function because they're potentially getting arrested for assaulting other people or stalking other people, etc. This has to be going on after the age of 18. And then we have these specifiers for all of the disorders in a controlled environment, meaning that they're in some sort of institutional or often correctional environment where they're not able to engage in these behaviors. And in full remission means that they've not had urges to do these things for at least 5 years and not just within the context of a controlled environment. You will see these specifiers on every paraphilic disorder that we talk about. And so it's important to note these things if someone is in a controlled environment or if someone is in remission. So the next is exhibitionistic disorder. These are our flashers. So these are individuals who receive arousal from exposing themselves to, again, a non-consenting person. And they've actually acted on these things with a non-consenting person. So again, these are the people in the subway who have nothing under their trench coat and they show you what they got and then they take off. We have specifiers related to, of course, those controlled environments and remission, but specifiers related to whom they prefer to do this. This is specifically exposing themselves to children or mature adults or both potentially. Frauderism. So frauderistic disorder is rubbing against or touching a non-consenting person. So again, I don't know why these things tend to happen in the subway. And we don't have a lot of subways here in Wyoming, but if anyone's ever spent time in the subway, for whatever reason, these things happen a lot. So in the subway, these are individuals who are rubbing their genitalia up against another person in a way that they find arousing without the other person consenting, and sometimes without the other person knowing about it. So again, it's not just fantasies or urges, but they've acted on these things with individuals who have not provided consent, which obviously creates a sense of distress and impairment in their ability to function. And we have the specifiers noted with the controlled environment and in remission like we do with our other paraphilic disorders. So this one's quite interesting. Sexual masochism. So this is finding arousal from acts of being humiliated, beaten, bound, and otherwise made to suffer. These individuals are providing consent. So it's interesting that there is this option when the notable difference here is that there is consent involved. And so there's some discussion about why this might still be in the DSM and whether it will remain in the DSM going forward, whereas there becomes a question of what is a healthy and consenting fetish and what is a disorder. And so with sexual masochism, the main difference from what we have right now is this marked distress, which we see across a lot of disorders in this category. So finding clinical distress or impairment in their ability to function because of these symptoms. So having that fetish or having that desire to connect with your partner in this way does not necessarily mean that you qualify for a disorder. It's really about that marked distress and impairment. We do have specifiers. Obviously, we have the controlled environment and remission, but we also have with asphyxophilia, which means that you're choking, you're restricting breathing, which obviously, again, with consenting partners may or may not be problematic, is particularly dangerous, just objectively speaking, if you're potentially cutting off someone's oxygen supply during sexual activities. So the opposite of masochism, we have sexual sadism. So getting arousal from instigating or perpetuating the suffering of another person. This one in particular is with a non-consenting person. So it's an interesting switch from masochism, whereas the sadism is a non-consenting person. So you are getting arousal from physical or psychological suffering of another person, and the other person has not given you consent to do so, which is a marked difference from sadomasochism fetish relationships where everybody has consented. Naturally, we start bringing up things like 50 Shades of Grey, and the entire first book of 50 Shades of Grey is about the process of them determining consent. So that doesn't necessarily meet the criteria here for this disorder because it's not a non-consenting person. So that marked distress across areas and impairment with those specifiers that we've seen across other disorders as well. So this one's always a bit interesting too. I say that about everything in this particular section. So pedophilic disorders. So over a period of 6 months, you see intense sexual arousal from considering the idea of sexual activity with children, generally under the age of 13. And this one in particular, again, is not just having the fantasy or having the urge, but acting on it. So this individual has perpetrated a crime against a child. They have perpetrated abuse against a child. And so if the individual is at least 16 years of old, they may be looking at a different type of disorder. So the age of the child in terms of the crime may or may not matter. But in terms of pedophilic disorder, the age of the child does matter, and the age of the perpetrator matters, because if the perpetrator is not at least 16 years old and at least 5 years older than the child, they do not meet the criteria. So this would not be a 14-year-old who finds themselves attracted to a 13-year-old. this would be like an 18-year-old who finds themselves attracted to a 13-year-old. So you have to have that age gap there for it to meet the criteria for pedophilic disorder. We do have some specifiers. So we have exclusive types, whereas the only way that you can get aroused or attracted is with children, versus non-exclusive types where you are able to achieve sexual gratification with others, not just with children. And then there's specifiers related to gender and incest. Incest meaning that this might only be happening with individuals with whom you are related, not with strangers. Next to last one, fetishistic disorder, so fetishes. And again, a little bit of an interesting context culturally here. So over a period of 6 months, recurrent intense sexual arousal from use of non-living objects or specific body parts, so thinking about our foot fetishes, or certain types of urges or fantasies, again, causing clinically significant distress. And this does not include things like cross-dressing or not specifically related to things like vibrators or arousal from, because it talks about non-living objects, but non-living objects that are designed for sexual gratification do not count. So you're not going to meet the criteria for fetishistic disorder because you own some sort of vibrator or sexual gratification device that is designed for that purpose. In the links of example videos in the module, you'll see Dave Cat and his girlfriends. I believe they eventually get married, and she is a living doll. She's literally an inanimate object, and he would meet the criteria for fetishistic disorder. However, there is some question about for Dave Cat, is this causing clinically significant distress? He seems to be really happy. And is this causing impairment in social, occupational, and other areas of his life? He seems to be functioning fine. So there really becomes a question of context and what is disorder? What is somebody's way of expressing themselves with consent in a way that they find satisfying and isn't necessarily interfering with their ability to function? So we have specifiers for body parts. This might be feet, hair, hands, different parts of the body, certain non-living objects, and then we have this sort of catch-all of other things that might be going on. Finally, we have transvestic disorder. Transvestism, thinking back to the concept of the term transvestite, that's where this comes from. So with transvestic disorder, there's a period of at least 6 months where you get sexual arousal from what they call cross-dressing, meaning dressing in the type of clothing that would be characteristic of the opposite gender from yourself. And this is not the same as being transgender. This is not the same as gender dysphoria. This is specifically related to cross-dressing. And so again, we're looking at clinically significant distress or impairment across functioning. So the fact that this is going on is not necessarily problematic. It may be a perfectly healthy and consensual way of expressing sexuality. It's really when this is interfering with somebody's ability to function. But as with all of the disorders in this particular category, hugely culturally based, hugely value-laden. And so think very carefully about those contexts when you're going to use these diagnostic labels. We do have specifiers down here of with fetishism. So if you actually are getting sexual arousal from the fabrics, materials, or garments that you're using and the feeling of them against your skin, and autogynephilia, meaning that you're sexually aroused by thoughts or images of yourself as a female. So if you're a male identifying person and you're most attracted to yourself as a female, that specifier might fit. We might also look at things like narcissistic personality disorder. So we also have those same specifiers about controlled environment and remission. So this particular category of disorders is quite interesting, a little controversial, and hugely based on things like cultural context.